Happy Friday, Baylor College of Medicine and friends of Baylor College of Medicine, and you know who you are. Interesting week. Every week is interesting in the land of COVID. But it looks like, as I had predicted a few weeks ago, it looks like things are turning around. New cases in the U.S. are falling, pretty dramatically. Here in the Houston community, things are getting better. Our number is now pretty consistently around 1, sometimes below 1. And our testing rate is definitely falling. We're down to 10%. We were at a high of over 15%, so that's all looking good. And the good news is if you look at the trends over the TMC period of time, you can see a very consistent drop in the number of cases on a 7-week rolling average. For some reason, our community numbers continue to be pretty high. We were over 3,000 cases on Wednesday. I expect these to drop, but we continue to have a large number of cases in the community, and that disconnect between the community and hospitalizations is a little unclear. I'll have to look at some more of the information coming out of our wastewater surveillance. But the good news is on hospitalizations we've had a pretty significant and steady drop in weekly hospitalizations, as you can see. And we never even reached the peak at the worst time, which was in late June, early July. So, yeah, it's worse this peak. We were at 335 cases per week. In the early summer, it was about 360 cases. Unfortunately, almost 4,500 people have passed away from this disease. And if you think about what's going on in the United States, we've reached almost 450,000 deaths and 27 million cases. And I'm quite sure we will get to 500,000 deaths before too long. So it's been a real slog for our country and been very difficult. The good news is vaccines are being rolled out, and that's very positive. Now, I don't know how you personally feel, but when I watch the national news, it sounds horrible. Everything sounds terrible. Even though we're rolling out vaccines, it's not fast enough. The variants are scaring everybody. The numbers are still scary. But I think you have to put it in perspective. I think we are turning the corner. I think we are seeing the light at the end of the tunnel. The tunnel may be still pretty long, but I think we're getting there. We are seeing the emergence of variants in the United States. There are 33 states that have the UK variant, that's that B.1.1.7, with 550 cases reported. That variant is very clearly responsive to all the vaccines. We have 2 states that have reported the South African variant with 3 total cases. That one we think is probably partially resistant to some of the vaccines, but probably not so much that it will really impair their efficacy. At least we don't think so. And then, of course, the Brazilian variant, which is the scariest one of them all. I'm going to call it the piranha variant. The piranha variant. That one has now arrived in Minnesota. Why it would go to Minnesota, I have no idea. From the Pantanal of Brazil to Minnesota. I think it got on the wrong plane. But in any case, that one is a little bit scary, and we don't know what's going on. But the good news is we have a lot of vaccines available, and we have a lot more in development. You remember I talked about how the mRNA vaccines work. That's a single strand of RNA that is coated by lipid nanoparticles. It gets into the cell very easily, and it encodes the spike protein, and that's how you generate immunity, both T-cell, memory T-cell, as well as antibodies. The new ones coming out that will be approved, the Johnson & Johnson and AstraZeneca ones, are a DNA vector. It's an adenovirus vector. It's a common virus that we all get as kids. And that one is easily manipulated, and so it puts in a piece of DNA, part of the spike protein encoded by the DNA, gets into the cell. That then moves to the cell nucleus, where it is transcribed into RNA, and then into the cytoplasm, where it's translated into the spike protein. And then the same exact thing happens as the mRNA vaccines. The difference is, because it's encoded by this adenovirus instead of the lipid particle, you tend to have an immune response to the adenovirus. And because it's a double-stranded DNA, it gets into the nucleus, it's transcribed and then translated. There's another step to get it into the nucleus. But they're just almost as effective, 75% effective. If you look at the modest differences between these, if you look at the AstraZeneca is an adenovirus that is very common in chimpanzees, and I mentioned that before. That way humans aren't really seeing that virus, and so they won't have as big an immune response to that vector. The Johnson & Johnson one is adenovirus 26. The usual virus we get as kids is adenovirus 5, and so the 26 variant isn't one we see either, and so the idea is you don't get a big immune response to that. And then the Russian Sputnik is a combination of adenovirus 5, which is common, and adenovirus 28. And the early results from the Lancet study look like it's almost as effective, pretty close to 90% effective. So we don't know. We'll see. But that's all good news. It's good that the Sputnik vaccine has been being developed. We need a lot of vaccines for the world. And Novavax is in process. I think we'll see that soon. That's just the spike protein complex with nanoparticles. And that should be effective as well. So we have a lot of really good news going out this week about vaccines. We are up to about 10.5 million vaccine doses per week. Unfortunately, at that rate, if you think about trying to get 250, 260 million people vaccinated, it's 6 months from now. That's probably not fast enough. We need to accelerate that. And I think if we could get that 50% higher, like 15 million doses a week, we could get us there in 4 months, which I think is a much more reasonable strategy. In addition to that, the White House announced that there's developing these private-public partnerships with 21 different pharmacy partners. That's really an important step because these vaccines that are coming on can be sent to these pharmacy partners who can get it to the people in rural communities and other communities that are harder to reach with the ultra-cold requirements for the Moderna and the Pfizer vaccines. There's new data from AstraZeneca showing that the virus actually reduces qPCR detection of the virus. That's good news. We've talked about just because you're vaccinated doesn't mean you can't necessarily transmit the virus to somebody else. In other words, I may be vaccinated, but I could get the virus replicating in my nose or my mouth. I'm not sick from it, but I can transmit it to somebody else. Well, there's a study that AstraZeneca did that showed that there's a pretty significant reduction in even being able to detect the virus in nasal swabs. So that's a very good and positive sign. And I mentioned the study in Israel that also looked at a small number of patients and had the same report. I mentioned that Sputnik 5 is out there. That's a good thing. And as I said, Novavax is coming on. So the more vaccines, the better. I still get the question every week, should I get vaccinated? Well, I thought I'd put it in perspective. I keep trying 1,000 different ways to explain why you should get vaccinated, but let's try this one. If you add up all the clinical trials that have been done, there's about 100,000 people have been vaccinated. No one has died, and there have been very, very few hospitalizations of those people who have been vaccinated. And the few that were vaccinated spent a very short period of time in the hospital, the few that got sick. Now let's look at COVID, 100,000 infected COVID patients. Well, there'd be 200 dead people and several hundred in the hospital. And compare that to flu season where you get about 10 to 20 deaths per 100,000 and 150 hospitalizations. So, I don't know. Does it make sense to get vaccinated? No deaths versus 200? I mean, really, this is kind of like a no-brainer. So I just think it's really important that if you have the opportunity to get vaccinated, get vaccinated. It's good for you. It's good for everyone. Now, because there's so much talk right now about the vaccine rollout, the variants, there's very little. I've heard very little in the news, about lessons that we've learned or things we should be planning for in the future. And so I thought I'd take the opportunity to start thinking about that. And I even want to come up with a plan, a 10-point plan, which is unnamed, but I could use your assistance in naming it because it's got to get a catchy name like Warp Speed. So let's think about the lessons we've learned. So what has worked? Well, it turns out mask wearing really works. Physical distancing really works, and hand washing. Those things that we've talked about all the time, they really, really work. The other thing that works, and I know many of us have done this, is developing small pods of friends that you know are following the rules, worker pods, small groups, so that you don't get infected with folks. So that has actually been a very effective way to still remain socially connected while maintaining physical distance with most people. The importance of ventilation. We don't talk about it enough, but ventilation and airflow. That has been a major part. We know outdoor activities are much, much safer because of ventilation and airflow. What are we doing to start thinking about buildings, now for the future? We know that middle schools and elementary schools have been pretty safe. We haven't had major outbreaks, although we have had outbreaks in high school, of course, and colleges. And then the other thing we've learned is that, all the surveillance methods that we thought would work, voluntary, stuff, they don't. It's really qPCR testing. In order to really detect asymptomatic cases, we have to do the PCR testing, and places that have done that have effectively controlled the outbreak of virus. So what things really have not worked? Spin classes, gyms. I mean, there was a huge outbreak in a Canadian spin class. And they took every precaution in the world except took off their masks during the spin class. Well, in contained spaces, it doesn't work. Restaurants, big risk factor. Choirs, as we talked about, enclosed spaces. Huge outbreaks in colleges and universities, probably because of fraternity parties. Dormitories. We had that great case of the Marine Corps recruits that were on a campus. Roommates got infected. That's what happens. Put people in a closed room, they infect each other. Super spreader events like funerals, birthday parties, weddings. These are all things that we have learned are really bad to avoid. And the other thing that's been a big disappointment is contact tracing. Contact tracing has just not worked in the U.S. A couple reasons why. I think we've had too many cases, for one thing, and culturally, we just don't like to give information to the government. So whatever reason, contact tracing has been, I'd say, a complete bust for us. And then, of course, we did not really predict the emergence of variants. We knew they would happen for all those RNA virologists out there. We knew there'd be changes, but we're getting a lot more variants than we predicted, in part because there's so much viral replication. And the things that are still really unclear, temperature screening just has not been effective. Maybe 5 to 10% of the people are getting fevers when they get sick, or asymptomatic carriers. We don't detect changes in temperature at all. Symptom screening, stand at a front door and check for symptoms. That really hasn't been very effective. There's been very little evidence of surface transmission or fomite, like when people are washing their groceries and stuff. That's been really nothing. We don't really know if plexiglass barriers have worked. And we're still hoping that the frequent use of antigen capture tests, which are just coming out, may work, but again, we don't know. So what I'm worried about, actually, is that Project Warp Speed was really intended to get us vaccines as fast as possible, but that is not enough. So we need another version 2 of Warp Speed. I don't know if I should call it Project Lightspeed, the Klotman version 2, Turtle Speed, Thoroughness, I don't know what we should call it, but if you got a catchy idea, send it to me. But I have a 10-point plan. The first thing is I really liked Jim McDevitt's July 4th Independence Day target. No one has announced a target to get herd immunity. I think that would really be helpful. I think we should target a time and go for it. I think we should be targeting 15 million doses per week. And I think we haven't talked about the distribution of these various vaccines, but it makes a lot of sense to take the Johnson & Johnson and AstraZeneca vaccines into places like in rural communities and harder to reach communities because they could be refrigerated and given in smaller aliquots. So that's a very, very important thing. It seems like the RNA vaccines that require ultra cold should be in urban centers and hospitals and places that they can manage the cold storage. And then another thing that's not very popular right now, but I'm certainly going to do at Baylor College of Medicine, is consider vaccination as a prerequisite to work. There's still a lot of resistance to vaccination, and there's precedence for this. In 1905, there was a Supreme Court case saying, you know what, if you have smallpox, you can force people to get vaccinated. Well, I don't want to force people, but I think employers, colleges, universities, communities, places Hospitals, we can tell people you can't come back to work unless you're vaccinated. And I think that's what's going to be required to get to that 80 to 85%. Where's the talk about the strategy for global vaccination? I haven't heard it. I was very pleased, as I suggested before, we rejoined the World Health Organization. Well, the first thing the Biden administration did was rejoin WHO. But the USA and the World Health Organization and the World Bank need a strategy for funding and providing vaccinations worldwide. And by the way, Russia and China have vaccines. What a great opportunity for us all to work together in accomplishing one task, which is to free the world of this particular coronavirus so that we can go back to doing what we do best, traveling around and having fun. So I think that's something we really could do as a vaccine policy, almost vaccine diplomacy. Very few people will realize that we, along with the Soviet Union in the height of the Cold War, developed together the vaccine for polio. And I think this is another opportunity to bring countries with real problems politically together in accomplishing an important task for all people. Where's the massive sequencing effort? We have sequenced 50,000 sequences. There's a couple of people around town who've done 1,000 here, 1,000 there. We need millions of sequences, and we have the genome centers to do it. Where is the national effort to sequence all of our viruses? We should be on top of this. Every time that virus hiccups, we should know what sequence is there, so we are completely on top of the changes rather than following other countries and not really having it in. We already have a repository. Los Alamos keeps all the HIV sequences. We have an infrastructure for it because of the genome science centers. Let's have a massive sequencing effort. That's my third piece of the 10-point plan. We need a massive home testing plan. With these antigen capture tests, people should be able to do it at home, test if they're positive, get confirmed, and then get that virus sequenced. We need a plan to engage people at home. And right now, we should be planning for what's called a polyvalent vaccine. That's where a vaccine has multiple different strains in it. That's coming. It's obvious. It may be coming in the fall near a theater near you, but that's something that we clearly should be doing right now. There's also should be massive funding, I think, by the NIH and other agencies on a universal corona vaccine. Remember, we talked a couple of, maybe a month ago, about the fact that there's certain people who've never been exposed to this particular coronavirus that have antibodies that recognize it and also have T-cell immunity that recognizes it. That's probably because it's another coronavirus that they've been exposed to. But there's one part of that spike protein that changes, and there's another part of the spike protein that stays the same. And that constant domain, and that's where the antibodies and the T-cell recognize, that could be a very good target for a universal vaccine. I know there's some academic institutions working on it. Keep working on it, and we should fund that. That should be a big push for the future. I mentioned last week the work by a group of scientists that are working on what's called the interactome, the 3 coronaviruses that have caused problems. What are the pathways that are in common? We should be funding small molecule, orally available small molecule inhibitors of these viruses, much as we do for Tamiflu. So you can take a pill and be able to fight this virus off. It's really important that that be a big part of our future research efforts. I haven't heard a lot about making indoor spaces safe. We should have a massive undertaking around how do we improve ventilation of buildings. Do we include UVC filters in all future construction? What's the guidance on masks? Do we need 1 mask, 2 masks? What kind of masks? These are sort of haphazard. There's been no really great guidance from the federal government on this. And clearly we're going to have to continue to restrict international travel as long as the global viral burden is high. And then 2 other important things, I think, are, wastewater surveillance has been very effective in the city of Houston. That should be a national strategy. We should be doing wastewater surveillance and begin to roll that out as ways to narrow down outbreaks in cities and counties and homes, in prisons. This is a really important thing that we just need to fund and really get using in our daily surveillance. And then finally, as I've mentioned before, the public health data infrastructure needs work. We need a central repository of numbers of truth. It happened that Hopkins has become the main repository. That's not right. The CDC should be doing this. So we need a big-time infrastructure for data repository. where we can all go for the truth around all numbers, and it ought to be in real time. So those are the things I think we should be thinking about as a future national strategy. It'll help for this virus, and it'll be helpful for future viruses as well. And finally, I just wanted to end by giving a big shout out to all the folks who fund the research that we do. The NIH, the CDC, DARPA, the Department of Defense, and all our donors. Our donor pool stepped up in a big way to help Baylor College of Medicine really ramp up our research efforts for this. But there are many donors all over the country who've done the same for their institutions. They have really been important in our ability to ramp up and really provide the support that was missing from the federal government. So big shout out to the donor community. We couldn't do this without you, the personal donors as well as the federal donors. So thank you so much. A lot to think about. Give me a good name for Klotman version 2.0, and I can't wait to see you next week.